Now here the picture shows us this is a lymph node, many lymphocytes. And in the sinus of lymph node, we can see these big cells, these atypial cells. This is tumor cells, these big cells. So this means the metastasis to the lymph node, And there is another classification, Laron classification of stomach carcinoma. From histology, can divide it into tubular growth. Tubular growth, the tumor cells form the glands. And another type is signet ring cells, these two subtypes. And for the growth pattern, can be divided into intestinal or diffuse type. This is one kind of classification. Another kind of classification is mean classification, just from the growth pattern divided gastric carcinoma into intestinal type and expansive type. Okay, this is the main adenocarcinoma of stomach. And now let's see the lymph node in the stomach. The main subtype of lymph node in the stomach is mild type, mild lymphoma. And usually, from gross view, we could not find any mass, any ulceration. This kind of lymph node, we can see here is the monocytoid tumor cells, monocytoid tumor cells, and the lymphoepithelial lesion. That means the lymph cells infiltrate the epithelia. This is the character of lymph node. This is the character of lymphoma. This lymphoepithelial lesion. Here also we can find lymphoma that can be cured by this. This lymphoma, mild lymphoma, can be cured by eradication of HP. So usually for mild lymphoma, we can use this antibiotics to HP. Here we can see this is the glands, and here we can see some lymphocytes. From gross view, we have a look of this stomach lymph node. This is the swelling, looks like swelling, and a small ulceration here. This area on the surface we could not find lesion, but on the cut section, on the cut surface, we can see here the cincture of the mucosa, So for clinical future, the mild lymphoma can cause bleeding, anemia, and sometimes will cause this monoclonal game pass. Okay, now let's have a summary of esophagus and the stomach, the histological classification of the carcinoma in different organs. For the benign tumor, for esophagus, usually papilloma, and for stomach, adenoma. For the malignant tumor in esophagus, usually 90% is squamous cell carcinoma, and about 10% adenocarcinoma. But for stomach, more than 90% is adenocarcinoma. And there are some rare type in the esophagus. And for stomach, we also can find this leiomyoma, GIT, and this mild lymphoma. So this is the first part, the disease of esophagus and stomach. Now let's see the second part, the disease of small or large intestinal. So first, we have an overview of the pathology of large intestinal disease. There are several types. Ischemia and enterocolitis, including some syndromes, and this is special disease. Idiopathic inflammatory bowel disease. We call it IBD, including Crohn's disease and ulcerative colitis. So this is the inflammation, and here is the obstruction. Order, this is the diverticular disease. And the last is tumor, including benign tumor and malignant tumor. So today we will introduce this disease. So this is first ischemic enterocolitis, ischemic. So this is one kind of infection. We can see the small intestinal enlarged, and the surface is black. The possible cause of this disease may be shock, or invagination, or volvulus. Order is associated with the vessel, venous thrombosis or artery thrombolism. So here show us the invagination. Here you can see this is the lumen of the intestinal, and inside the lumen we find mucosa, or we find another part of the intestinal, and this intestinal, inside the intestinal, looks black. Necrosis is gangrene. So let's see the disease, the inflammatory disease. So here show us the balance of water of our body. The drink, the excrete by body, the several, the gastric juice, the bile, and the pancreatic juice, also the secretion of intestinal. And here is the excreted. For the inflammatory disease, usually associated with virus, the mainly virus is rotavirus. This virus always infected these children after weaning towards the age of 4 to 5 years. And this kind of inflammation will cause death, 1 million deaths. And except this rotavirus, adenovirus is also the common virus to cause this inflammation. And the second factor is bacteria. The bacterial toxin or the bacterial infection can cause the inflammation. And the third is the antibiotic associated colitis. This is the schedule membranous colitis. So this is the normal bacteria which live in the gut, and the antibiotic therapy will destroy this kind of bacteria. So the bacteria is imbalanced in the lumen of the intestinal. Then can find this kind of antibiotic associated colitis. And usually the character is schedule membranous for formation. So here, this patient this disease occur 1 week after antibiotic treatment. We can see many, this yellow are schedule membranous. This is the schedule membranous and enterocolitis. And microscopically, we can see here, this surrounding area, they are normal, mucosal, submucosal, muscular, and serosal. And here, we can see this is the schedule member, including necrosis, including infiltration cells. And here, we also find when this area necrosis and consists schedule member, we can see the ulceration, here ulceration. This picture also shows us here necrosis, necrosis. We can see the fibrin cap, necrosis, and then consists schedule member on the surface. And when this member loose, and we can see this ulceration. Here also, this is the schedule member. When this member loose, here is ulceration. And there is a special disease. This disease is associated with this food. For this patient, they are hypersensitivity to the gluten. This is the protein component of wheat. This kind of disease usually occur in the West country. And we can see for the biopsy, we can see the interepithelial lymphocytes increase, and the villi will destroyed, atrophy, and the patient will malresorption. Let's have a look. This is under electric microscope. This is normal. We can see the villus, villus architecture. We can see here is small leaf-like villi. Here is the finger-like villi. Here is the broad leaf-like villi. But here is the disease. The villi atrophy, we can see the cracked openings. The villi atrophy destroyed, disappear, and the cryptic opening. And for this kind of disease, there is a Marsh classification according to the interepithelial lymphocytosis, and the villi, the atrophy of villi. And for this section, for this picture, the Marsh classification is Marsh 3C, total villus atrophy. And the second inflammatory disease is caused by the parasites. We can see here the egg, And when it deposit here, the organ, the body will form the granulation, granuloma. Here we can see mucosa and submucosa granulomas surrounding the eggs and their rhinates. This is granuloma. Here, granuloma. And this inflammation caused by radiation, called radiation mucositis. We can see the surface, the epithelial cells destroyed. There are no epithelial cells. The loose or superficial cells. And the second, we can see the goblet cells also completely loose. So, for this tissue cannot produce this mucus. Okay, now let's see the important part, this chronic inflammatory bowel disease, idiopathic inflammatory bowel disease, Crohn's disease and ulcerative colitis. So this picture shows us the difference between Crohn's disease and ulcerative colitis. For the Crohn's disease, the lesion is scape-like, not continuous, scape-like. And half of this disease occur in the upper gastrointestinal tract. But for the ulcerative colitis, the disease or the lesion is continue, and it starts distal limit to the colon, from distal then continue, limit to the colon. So first, difference between two diseases. Second, under microscope, Crohn's disease, we can see the abscess, cryptic abscess, and usually fistulation, and 40 to 30% we can find the granulomas. The inflammation always involve the whole wall of the bowel of the large intestine. This is the Crohn's disease. But for the ulcerative colitis, we can see here, this is chronic inflammation. Just involve the mucosa. Mucosa is not so deep. It's just involve the mucosa. But the risk of this kind of disease is it could dysplasia and develop to the carcinoma. So here is the picture. It's the slide of 47-year-old woman. He had the disease for years, and for biopsy we find the chronic inflammatory cells, lymphocytes, and the lymphocytes proliferation. And for this kind of disease, the pathogenesis is not so clear. Just think the factors can activate the host immune system. It's associated with immune system because there are systemic disease with the patient, patients. And the second is host defense to downregulate inflammation and maintain the integrity of the mucosa. For this disease, there are genetic predisposition. For example, this monozygotic twins, they have this disease 30 to 50 both have this disease. And also the disease is the HLA association. And for Crohn's disease, it's associated with NOD, NOD2. And for immunological factor, we say that in Crohn's disease, the granulomas is associated with this T help cell, T helper 1 cell hyperreactivity. And in the ulcerative colitis, is T helper 2 hyperreactivity. Okay, now let's see the Crohn's disease. This is first description by Crohn, so means Crohn's disease in 1932. They find this disease usually in the terminal ileum. So this is the terminal ileitis. Second, the involved and uninvolved segment may be sharply demarcated. That means scalp lesion. That's not continue. It's regional. So now today, it is known that every part of gastrointestinal tract will be involved. And this disease is high also in the West country. It's about 3 per 100,000 in England and in the Europe. And in the Europe up to 4 to 10%. In the in this age, it is weak. It is peak incidence, and smoking is a stronger factor associated with Crohn's disease.